Hello, and welcome to our webinar on geriatric spinal cord injury, complications, fixation strategies, and biology of recovery. And I would imagine that there are people really from all over the world. So wherever you are, whether it's morning, afternoon, or evening, please be welcome. I'm Dr. Michael Failings from the University of Toronto. I will be introducing my co-chair, Professor Chabra, in a moment, and our other faculty. This is an effort through the International Spinal Cord Society, or ISCOS, the Spine Trauma Study Group, which Professor Chabra chairs. And this is in collaboration with AO Spine, and specifically the spinal cord injury and the spine trauma and infection knowledge forums. So here we are, your two co-hosts. So I'm Michael Failings from Toronto, and Professor Chabra, a very distinguished academician from India, and we welcome you here. And we're really very honored to have an amazing faculty joining us in no particular order, but just on the screen, as you see, Dr. Daryl Fields from the University of Florida, Dr. Klaus Schnacke from Paracelsus Medical University in Germany, and Dr. James Guest from the University of Miami. And we have case presenters from Thomas Jefferson University, and these are surgeons in training under the supervision of Dr. Alex Vaccaro, Roy Malo, Mitchell Ng, and Abdullah Mahmoud, and they'll be undertaking case presentations. So just a few introductory comments. Aging is a natural and inevitable physiological change that leads to compromise in physical, mental, and functional abilities and represents a decreased capacity for regeneration and repair. And this is becoming a real issue because the epidemiology of spine trauma and spinal cord injury is changing, as we reflected in our Lancet Neurology article entitled The Global Burden of Traumatic Brain and Spinal Cord Injury. And specifically with spine trauma, we're seeing that the overall incidence is stable, and it's probably actually rising. And we're seeing older patients, more fall mechanisms, and more cervical injuries. And this is just a couple of papers from our own group, just showing the shifting landscape of spinal cord injury. And here we're contrasting the peak age from the 1980s and 1990s, with the average age being in the late 20s to early 30s, shifting now to current times where we're seeing a shift in the age to around 50 years of age. So really quite a remarkable shift. And this heat map just illustrates the shift in the causes of injury. So in the 1990s, we see a lot of sports and motor vehicle collisions. These still occur, but we see now in the heat map a high prevalence of fall-related injuries. And of course, on top of this, we have the aging of the spine, which is a reflective of the shift to chronic degenerative conditions. And here, we see a patient with cervical myelopathy. We have patients with underlying degenerative diseases, fragility fractures, such as this odontoid fracture. We'll be discussing a case with an odontoid fracture, issues related to bone quality. So here, we've got a patient with cement augmentation and, complex deformities with kyphosis, spondylolisthesis, and so on. And we're all aware of this. And then when you have these underlying issues with a superimposed traumatic injury, this becomes quite challenging. And of course, the elderly are more susceptible to injury for a variety of reasons. And there are physiological changes that occur due to senescence, which I think will be discussed later in the lecture. And we've seen a five-fold increase in the spinal cord injury-related hospital admissions of geriatric patients in highly resourced countries. And the reality is that spinal cord injury is becoming a medical issue of the elderly. And this also has an important impact in survival. And these are some some epidemiologic data from our group in Toronto, just contrasting the survival with matched controls in younger patients and older patients, and there's quite a dramatic difference in the survival curves. So today, and this is the second webinar that we've done, the previous webinar is also available as a podcast. We have case presentations. For logistical reasons, we may actually pivot initially to the keynote presentations, and we'll actually go with Dr. Schnake first, followed by Dr. James Guest, whose presentation will be done in video as he's currently traveling internationally. And then we'll be getting into the case-based discussions. I will be moderating the first portion of the webinar, and Professor Chabra will then be handling a lot of the the discussions and providing concluding remarks. I will pivot and ask Dr. Klaus Schnake to kindly share his presentation, and I think what we'll do is we'll do our lectures, and then we'll follow this with the case presentations and the discussion. So, Dr. Schnake, over to you, please.
So, dear colleagues, dear friends, dear Michael, dear Harvinder, thanks a lot for the invitation to talk about, stabilization. So, osteoporosis and vertebral fractures are worldwide increasing in problems. So, it's a kind of tsunami we're facing, where the prevalence of vertebral fractures in the elderly range worldwide between 80 and 51%. And not only the fractures are coming to us, but the frailty among these patients is high as well. So just very recently, a study was published just in Germany. Patients over 80s, they have in more than 50% are frail. So we have frail patients with a lot of fractures, and that's actually what we have to deal over the next years with. And not to forget that the fertility fractures increase mortality, so it's clear that with a fracture, you risk increase, unfortunately, to die earlier than you should, and especially in comparison to hip shoulder forearm fractures. And although the typical treatment of osteoporotic fractures is conservatively, we see that after half a year, between 30 and 25% of the patients develop non-unions. And when patients have a very low T-score, progressive kyphosis is common. So in a combined attempt of AO Spine and the German Orthopedic and Trauma Society, we have developed a classification and published it a few years ago in order to give more structure. We talk about what of these osteoporotic fractures. And when it comes to surgery, and when it comes especially to neurologic deficits, the OF4, where both end plates are affected, and the OF5, where mostly the posterior ligament complex is affected, play a role. However, the incidence of neurological deficits is rather low. It's about 3%. In the acute phase, it's typically more on radiculopathies, mostly due to incomplete burst fractures, so mostly O3 or O4. But in the long term, when the PLC elongates and then gets insufficient, patients can develop spinal cell stenosis and even develop cauda-equina syndrome or whatever. And in order to give a hint or some recommendations with regard to therapeutic decision-making, we have developed this OF score, which takes neurological symptoms into account. And here we get 2 points if a patient has neurological symptoms, and that clearly triggers surgery. So the typical fracture on OF4 or O5 typically gets together with the neurological symptoms, gets a recommendation to perform surgery. The next cases, as well as the results I'm going to present based on one of our multi-center studies we've performed and published recently, the EOFTT study, where we evaluated prospectively in 17 centers in Germany, more than 500 patients. We followed the treatment recommendations and published the results and OF5 fractures. So if you're interested in, please feel free to read these articles and see how we, at least in Germany, have treated the patients surgically as well as conservatively. So what are our surgical options? They're numerous. They start with an either vertebroplasty or kyphoplasty and end up with a maybe anterior posterior or constructor osteotomy. So kyphoplasty and vertebroplasty are typically the workhorse for easy fractures like normal compression fractures, OF2, OF3, and sometimes even OF4. But if the patient has a neurological deficit, it's probably not the right thing to do. There might be some exemptions when you, for instance, have an old patient with a OF4 fracture, like in this case, when there's no severe kyphosis, and then you can perform a kyphoplasty or vertebroplasty, and for instance, then decompress the patient. But mostly it's reserved for as a pain treatment for patients having osteoporotic fracture without severe kyphosis. The working horse on the other side for the typical fractures are the hybrid constructs, percutaneous stabilization with cement augmentation of the screw, plus minus in vertebroplasty or kyphoplasty of the index vertebral body. This works quite nicely, and however, in some fracture types, it's not that easy to place cement. So in that case, for instance, here we performed the percutaneous short posterior stabilization where we put short screws at the fracture level, while we typically cement the screws above and below. Another case here where we have a patient with a failed conservative treatment who developed over time rhodogenic claudication shows clearly that some of the fractures do not heal well, like in this case here, where we had after a few weeks, patients came back with this rather old fracture here at L4, where you can see already sclerosis, but you can see clearly that there's a spinal canal stenosis. So here the treatment was a percutaneous stabilization with some augmentation of the screws, plus microsurgical decompression. So again, the typical treatment is minimal invasive. And these hybrid constructs are effective. There are several retrospective and even some prospective studies showing that these hybrid constructs, percutaneous constructs, are working well, and they're with a relatively low complication rate. However, in some cases, we need individual decisions, especially if you have multiple fractures, severe kyphosis, and then you sometimes need even to perform open surgery. There's an example of a patient, of a lady with a T6 and T8 for fractures, with an old T4 fracture. In this case, here you see the vertebral cleft at T6. This is actually a good thing which you can cement because mostly the cement goes in there. But since this patient had multiple fractures, we performed a percutaneous stabilization. And what I would like to emphasize is here that today we only augment the uppermost and lowermost screws. So you don't have to augment all the screws because typically the implant problems you will see at the end of the construct, not in the middle. So mostly it's enough to cement the uppermost and lowermost screws. Well, anterior-posterior constructs or even osteotomies are sometimes necessary. However, then frailty of these patients plays a role. Here's an 86-year-old woman who had a fall 3 months ago. When she came to us, she could not walk anymore. So the right image is in a supine position. And so she could not walk freely anymore. She could not stand upright and complained about some bowel and bladder insufficiency. The MRI, you see clearly here there's an intravertebral cleft and the spinal canal stenosis. And when we perform the CT scan, we see that it's not really healed yet. It's a pseudarthrosis. The vertebral body is more or less gone. And you can nicely see in the posterior element that the PLC is elongated. So this was a former OF4 fracture, which further developed then progressed actually to an OF5, where then the posterior ligament complex just elongates and gets insufficient. And here we have the issues of a canal stenosis, the totally gone vertebral body, and the kyphosis. So the problem here is what to do. And in these cases, you typically need, to perform surgery. And then it depends a little bit on the patient and whether you are able to do this in a minimal invasive way. So what we did here was a percutaneous stabilization with PMMA augmentation, or decompression, and then followed by a thoracoscopic assisted mini thoracotomy, corpectomy, and vertebral body replacement. So this is a typical access from the anterior, as you can see. So we don't do classical thoracotomies today. So it's either pure thoracoscopic or mostly thoracoscopically assisted. And that's the result. So what you can see here is a relatively short construct with augmented screws and the cage. And here it's important to use square, big end plates in order to avoid subsidence. So typically we use the long end plates with go from one side to the other, where the end plate is based on the apophysis rather than on the cancellous bone to avoid subsidence. And furthermore, we segment, augment, the screws with cement. So even when the cage starts to subside, it stops at the cement. And this is already the 12-month follow-up. And if you more or less restore the physiological alignment of the patient in that age, 86, you can even have good results after 1 year. However, adjacent segment problems can occur. So lessons we have learned with regard to kyphoplasty, vertebroplasty are that in order to avoid cement leakage, we perform a vertebral body lavage in the beginning. So we use saline to perform a lavage of the vertebral body. We do not fill in more than 4 to 6 cc PMMA per vertebral body, 4 cc in the thoracic spine, 6 cc in the lumbar spine. And we do not use it typically in marked kyphosis or pseudoarthrosis because it doesn't work there. It's more a pain treatment. Screw augmentation is very helpful, but only the top and bottom screws are mostly should be augmented. We start in the lower on the lower end of the construct. So if you have a T10 L2 construct, for instance, we start with cementing at L2 and then go up in order to wait so that at the upper end we have the most stuffy cement, and we do not use more than 1.5 cc per screw. And if we have to use corpectomy cages, which is not that common, but if we use large footprint, as well as carefully expand the cage. However, there are some unsolved questions, especially with regard to the length of the stabilization. The lessons we have learned here are that the higher the kyphosis, the longer the construct should be, because the more you reduce the fracture or the more you correct the deformity, the more power you apply, and therefore you need multiple points, to support your construct. And especially at the junctional zones, you will see a couple of implant failures. So again, here in the junctional or thoracolumbar area, you should probably use a longer construct, 2 above, 2 below, or even 3 above, 3 below. So in conclusion, these fractures shortens patients' life expectancy and unfortunately do not heal in up to 25%. The classification and the score are evaluated tools for the decision making. They help in the daily practice. Short percutaneous augmented stabilization works in the majority of the cases, plus minus decompression if you have a neurological deficit. However, more aggressive surgical strategies are sometimes necessary for the failed conservative cases, so don't wait too long with your surgery. And of course, comorbidity, adjacent fractures, and implant failures are still challenging, and we're working to overcome this. And with this, I'm already done. And I thank you for your attention. I'm happy to answer questions. Thank you very much.
Yeah, thank you very much, Dr. Schnacke. Excellent lecture. And I realize that you have another commitment. So perhaps we'll just maybe briefly have a couple of questions. Dr. Rishi Khanna had a question. If I may summarize Dr. Khanna's question, basically, when do you think it's appropriate, in summary, to have conservative management, and what's the best protocol for conservative management?
So if the patient is able, if you can mobilize a patient within a few days, if the pain is treatable, so pain is below VAS or NRS is below 5, patient can walk, then mostly it's a sign of stability, and then patient can mostly come along with conservative treatment. That we think that in the elderlies, an orthosis play a role. So in contrast to the young patient, it is a help for the elderlies to use a brace or orthosis. So this, you can think about it. We recommend to perform X-rays, standing X-rays within the first 2 weeks to see whether the patients develop kyphosis or the vertebral body compress further. So we want to avoid kyphosis. And yes, you need adequate pain treatment. That means that you should have a look that these elderly patients do not necessarily take NSAIDs, but probably something, and not too many opioids. So the pain treatment can be a little bit tricky, but should be adapted to the patient's age. And then a close follow-up, and typically after 4 to 6 weeks, the fracture is either healed or needs probably surgery.
Thank you very much. I also wanted to introduce and acknowledge Professor Vafa Rahimi Movahar from Iran. So thank you for joining us in the discussions. Dr. Abdallah Mahmoud, thank you for joining us. We'll be deferring the case presentation discussions until after the lectures. And Dr. Daryl Fields, I wonder if you could perhaps just briefly comment on Dr. Schnake's excellent lecture and any remarks that you might wish to make in brief.
Yeah, I I think the attempts to first create a grading scale that guides intervention is specifically helpful for junior faculty that are, attempting to kind of look through the weeds because our literature on this topic is just so vague, right? So there's really no RCTs. So you're going to find a study to validate any reflexive move that you want to make. But having a scale at least gives us a grounding point to move forward. Augmenting the top and bottom screws, that makes sense. It makes sense. The risk of complications from cement are rare, but they're even rarer if we only use the cement that's necessary. So that makes a lot of sense, and I'm going to employ that as part of my practice.
Very good. Thank you very much. So I think we will now, thank you, Dr. Schnake. So I think we will now pivot to Dr. Guest's presentation. And I think that we will, Dr. Guest has kindly videotaped his presentation. So we will shift to Dr. Guest's video, please.
Hi, I wanted to thank you very much for the opportunity to be involved in the presentation tonight. I'll be talking about the biological changes in the aging body and nervous system that limit recovery after spinal cord injury. So age effects can worsen outcomes through definable mechanisms, and three prominent mechanisms are resilience, repair, and physiological reserve. What we're illustrating here is a systems medicine approach to thinking about this problem. So systems medicine is a way of encompassing multiple organ systems and thinking about how they define states in the body and health, all the way from the genome to the organs through the molecules that are expressed and cells that are organized. Over on the right, you can see sort of a systems map where there's been a perturbation on the right side indicated in red. And so there are downstream or upstream consequences in other systems from that. Here, what I wanted to illustrate is that classically we think about the spinal cord injury as exotomy, loss of myelin, microglial activation, and we really focus in on how can we repair this intrinsically. But what we really need to bear in mind, and has become increasingly obvious, is that the downstream consequences on different systems caused by the spinal cord injury feed back onto the injury, and they strongly influence recovery. And some of those are the metabolic dysfunction, the immune dysfunction, and in particular, the changes in the sympathetic regulation of various organs. So systems medicine is constructed from acquiring multimodal data. This multimodal data is interpreted through systems interactions. This can define phenotypes, which have primary leanings, for example, towards inflammation or towards metabolic disruption. When these systems interactions are well defined, they can provide points of entry for the types of therapeutics that we have available to us, and then we can determine whether these have a beneficial effect. So aging is measurably accelerated after spinal cord injury. This has been established several times, for example, in vascular aging, cardiometabolic, changes in cognitive function, notably changes in muscle and exercise are one of the most important axes, and in the immune system. So recovery is kind of an abstract concept. It definitely is multidimensional, but we can think about where an individual is starting from, as indicated in the blue sphere, where we think they can get to in terms of their constraining biology, indicated in the orange sphere, and then how we might be able to amplify that in the green sphere. So what underlies a state? So this is comprised of multiple variables, which are shown here. They can include the neuroplastic potential, the inflammatory tone, the energy that's available through the mitochondria, physiological reserve that an individual can put into their rehabilitation effort, and then the extent to which they're undergoing senescence at the organ and cellular level. So the level of injury is really critical variable here, particularly above and below T6. So injuries that are above T6 can be associated with very significant perturbation in sympathetic innervation of organs. These organs can essentially get somewhat out of control and lose regulation. We talk about this change from homeostasis as allostasis, which really means a distance away from the homeostasis balancing of the different organ systems. So allostasis is really about stress and increased load on these organ systems, and it can be amplified by various factors. For example, here pressure injury is illustrated, and this can accelerate biological aging. So some of the axes we're talking about have existing quantification, for example, frailty indexes and allostatic load indices. And then we have some emerging biomarkers of the potential substrate that's available for neuroplasticity, such as the mid-sagittal tissue bridge. Mechanisms that can lower the recovery ceiling include inflammaging, cellular senescence, mitochondrial and vascular aging, epigenetic restriction, and sarcopenia and metabolic decline. So this is an illustration of inflammaging. This is a very critical process that affects all of us as we age, and it includes a number of factors that are shown here, such as cellular senescence, changes in mitochondrial function, changes in gut function. And these mechanisms are linked. So this is called geroscience, and so these the linkage between these mechanisms is very important for these concepts, because targeting one of these, for example, sarcopenia, which could improve muscle stability, and then cytokine release could have widespread effects in different systems. We can quantify age biologically or in chronological age through established testing methods. So this is the phenoage, which takes a number of clinical and laboratory marker inputs and results in a calculation of the phenotypic age. These include liver, kidney, and metabolic markers, as well as markers from the circulating blood. And then with a knowledge of the phenotypic age, we can compare to the chronological age as calculated from the epigenetic study using the epigenetic clock. And then this can tell us the distance that an individual is away from their chronological age, and this could become a long-term marker of our interventions. So rejuvenation therapies are important as we think about changing the outcome of older people. And as I mentioned before, it's extremely important to emphasize the ability to exercise, the resilience to engage in exercise, as this can release myokines. Other approaches we have are senolytics to try and clear the body of senescent cells, and then epigenetic rejuvenation. This is a bit further afield. Currently involves gene therapy, but this is attempting to directly reverse aging. So there are these different reprogramming mechanisms. The most accessible right now is immune repolarization through various microRNAs, and the epigenetic reprogramming has not been introduced effectively into medicine as yet. So I was asked to talk about exosomes as a biologic. They're quite exciting. And so we can think about their therapeutic promise and their challenges. So exosomes are very small lipid-bound molecules that move between tissues and also circulate in the blood. They are involved in both pathophysiology and also in health. They contain microRNAs, proteins, and lipids. So we've been working with these for a number of years now at the University of Miami. So we're aware of some of the translational challenges which really relate to their reproducible manufacturing. The way that they work is that a microRNA recognizes a messenger RNA. When it binds to it, it leads to its degradation. So this is a way to turn off genes. So this is the summary. I've gone through a systems medicine approach to aging and some of the therapeutics on the horizon that we can use. And so aging after spinal cord injury is a distinct accelerated biology. We can quantify it. And then senolytics have been tested at the level of animal models, but they haven't really been introduced into practice. And so one of the promising ways of getting at the regulation of these gene networks is through exosomes and microRNAs. Thank you very much for your attention.
Great. That was really an excellent lecture, very informative. And I've asked Dr. Vafa Rahimi Movahar to comment on the lecture, please.
Excellent presentation. Frailty is a host biology, and age is just a number, but frailty is the multiplier. And for example, COPD or congestive heart failure and diabetes increases and has a poor prognosis and decrease the condition of the patient and related to frailty.
Thank you very much. And I think, Dr. Fields, I think you also had a question and a comment as well that I saw in the chat. Maybe you could address this at this point.
Yeah. So I think we're reaching an age where we're able to appreciate utilization of tools such as AI and prognosticating, which are based on having quality data inputs. But I think one thing that's not discussed is spinal cord injury is such a dynamic disease. We already know there's so many things that influence it. A acutely acquired infection will significantly change your trajectory for recovery. My question is, as we begin to, pull this data, what are the critical time points in which these data become, prognostic or where they become irrelevant? Is frailty important only in the context of, no other injury? Is the inflammatory profile only relevant, if they don't have an active pneumonia, or is it more relevant when they have a active pneumonia? So it's more beginning to filter these data points and say, how do we interpret in the realistic context of how we see patients clinically?
Yeah, thank you very much. And I think we'll have time for kind of further discussion. So at this stage, I'm going to hand over moderating duties to our co-chair, Professor Harvinder Chabra, and I believe we'll be transitioning to the case presentations.
Thanks, Dr. Michael Failings. I think Dr. James Guest is there online and he's briefly respond to the query by Dr. Daryl Fields. Dr. James Guest?
Thank you so much. Yeah, I'm just boarded on this flight. But Dr. Fields, I really appreciate your question. I do think that particularly as we begin to create the systems medicine for spinal cord injury, we probably are going to want to work with subacute and chronic time points initially. I think that it will be very difficult to interpret the information when there are superimposed complications, for example, like the pneumonia that you mentioned. So that's my first thought for your question. Thank you.
Great, thank you for that. Thank you for that comment, and have a safe flight. And thank you so much for accommodating this this webinar despite some of the logistical challenges.
So thank you, Dr. James Guest. Have a great flight again. Now we will move on, and we'll move on to the case presentations and case-based discussions. So we have Abdullah Mahmood here from, he works with Dr. Alex Vaccaro, and he's representing Dr. Alex Vaccaro today because they have at Jefferson today an alumni meet, and Dr. Vaccaro is busy with that alumni meet today. So, Abdullah, could we request you to please go ahead with your first case presentation on elderly adenoid fracture with neurological deficit? Yeah.
Thank you so much.
Right.
Yeah. So this is basically a presentation, as Dr. Vaccaro mentioned, of an elderly patient with an odontoid/C2 fracture with neurological deficit, presented by myself, Abdullah Mahmood. We have Workflow as well, which is a very important part of preparing this presentation, Dr. Mishla Ng, and of course, Dr. Alexander Vaccaro himself. Here's some of the disclosures for Dr. Vaccaro. So essentially, what we had here was an 85-year-old female who fell from standing height. And what I really want to make clear is she actually initially did not present with neurologic deficit. She did come in with a complaint of neck pain. However, she was always ambulating, of course, at baseline, and was continuing to be independent ambulatory. After a CT, we discovered a non-displaced type 2 odontoid fracture. The patient was hesitant to undergo surgical management and chose to basically go with non-operative treatment with a rigid cervical collar. And 6 weeks after the placement of the rigid cervical collar, we did discover that the odontoid fracture had actually displaced. Additionally, collar decubiti had developed. The patient was unfortunately suffering from very painful pressure sores from the rubbing of the collar around her neck and her other areas around the body. Surgery was reconsidered. However, the patient again, unfortunately, elected for non-operative management. 3 months after the start of the placement of the rigid cervical collar, unfortunately, the patient did lose the ability to ambulate, and deficit was acquired during treatment, of course, as I mentioned, not at injury. So for some definitive management, Dr. Vaccaro elected to do a posterior instrumented fusion, occipito-cervical, occiput to C5. Unfortunately, there also was a need for a partial craniectomy as well. However, what was the good news regarding this circumstance was the patient was fortunately able to return to full ambulatory function 3 months after surgery. Major summaries here: fracture displacement at 6 weeks. That was after the patient had elected for rigid cervical collar placement. The patient unfortunately also did suffer from pressure sores due to the rigid cervical collar. 3 months after presentation, while still in the rigid cervical collar, the patient developed a loss of ambulation, and occipito-cervical fusion was needed. However, fortunately, as I mentioned, the patient was able to return to full baseline ambulatory function 3 months or so post-op. Some of the discussion points for later, we have operative versus non-operative decision-making, posterior fixation versus anterior odontoid screw feasibility, the role of the halo vest in the elderly, risks and outcomes, polypharmacy, anticoagulation and perioperative planning, airway and respiratory risk management, shared decision-making and realistic goal setting, of course, and rehabilitation expectations and discharge planning.
Thanks, Abdullah. Probably you can now start with the case-based discussion for this case, and we have two panelists with you,
Sure.
Dr. Daryl Fields and we have Dr. Wafa Rahimi Mogawar. So both of them are the panelists for this case discussion, Dr. Daryl Fields and Dr. Wafa. So you could start with the case-based discussion. So Dr. Daryl Fields, what would you have managed this patient differently? Of course, the patient decided how to move forward, but
just as Dr. Thalines had stated, these are so difficult because um, there's a lot of disagreement on what the next step is. And, me being junior and being humble enough to say I don't necessarily know the right answer. But what I do in these decisions is I'm very risk averse. And in that sense, I think an older adult coming from an anterior approach is the thing I'm most fearful of, whether that's a nerve injury or whether that's causing swallowing issues that's going to, end up requiring them to have a feeding tube of some capacity. So I do favor a posterior approach. I think that we're able to get a good enough bone purchase to where we can often get away with just a few segments. I think this one went down to C5. I think that's very reasonable because in all practical sense, she has osteoporosis, right? So this is a fall from standing height. So it's a frailty fracture and it's a diagnostic for osteoporosis. So I think operation is critical, and I think posterior approach makes sense. I think the segment down to C5 makes sense as well.
thanks, Dr. Wafa. What are the factors other than age which you take into consideration before deciding which management you go in for?
First of all, lack of neurologic deficit is the most important factor that suggests to perform conservative management. But in this patient, we know that for surgery, better union, but more complications. About non-operation, there is a lower severe complications, but higher non-union. Therefore, we have to do individualize. About anterior versus posterior approach, there are comparable safety. Really, anterior fixation associated with lower opioid use. Therefore, we can perform anterior approach and anterior fixation in this patient. About halo vest, there is a 33% instrumentation complication rate. But we know that success in 94%, but high pin penetration to the skull or CSF leak or pneumonia risk is present. About anticoagulation, individualized management, bridging with enoxaparin or low-dose aspirin is safe with no major bleeding events. And about respiratory risk, older age is a key predictor of respiratory complications, low threshold for proactive airway management. And about shared decision-making, age is not a contraindication. Focus on frailty, medical status, and patient goals is important. And for rehabilitation and discharge, high mortality and non-union rates, plan for potential skilled nursing facility discharge is suggested. Thank you.
I might make a couple of comments as well, if I may. And I think,
Sure.
The original decision to manage non-operatively is not unreasonable, but I think what's important in the trauma situation, if you manage patients non-operatively, you want to have early follow-up, because if patients fail non-operative management, they'll generally fail early. So this isn't the type of thing where, I would say put a person on a call or bring them back to clinic in 6 to 8 weeks. I would actually, assess them very early, like a week or two. So that's one point, and I think that could have avoided some of the issues in this case. The second point, I fully agree that age has become a relative factor, and I look at the vitality of the patient and how active they are. So if you have someone, let's say, who is not active and they're very frail, they're cognitively impaired, I think your management there will tend to be non-operative. Whereas I think if someone is very active and they have a very active lifestyle, then I think the operative options start making more sense. And I think this is where the personalization of the management becomes important. And then from the surgical perspective, in my training, and Dr. Vaccaro and I have known each other for many, many, many years, and he and I have taught many courses where we have lectured to teach the anterior approaches with anterior fixation. But in this setting, I really will not use anterior odontoid screws. I think there's a lot of issues and problems, at least in my hands. And so here, if I was to operate, I would generally do a very focused C1, C2 fixation. Thank you.
Thank you, Dr. Michael Feelings. Before we come to Dr. Daryl Fields, I'll just summarize what has been the discussion so far. So it has been discussed that the optimal treatment for such a case is determined not only by the fracture type and the chronological age of the patient, but also physiological reserve, bone quality, fracture characteristics, and as Dr. Michael Feelings said, the functional goals of the patient. So we have to individualize the treatment in such a geriatric age group. Dr. Daryl Fields, you also had a comment to make.
Yeah, just looking for clarity from Dr. Failing. So when I have thoracolumbar fractures and I say I'm gonna do conservative, and I see them in a week or two, it's often asking them ambulation status. That's my trigger. For cervical spine, what are you looking for in that week or two that would necessarily put you one pathway versus the other?
Yeah, so I think it's multidimensional. So I think I would be one, making sure that the neurology is okay. And, it's not that common that patients will have secondary neurologic deterioration, but they can. And if that occurs, that's an absolute indication for surgical intervention. I would assess the extent of pain and the functional limitations. And I tend to really only use the collar for comfort. I don't really think it has a big impact on the healing. And the usual outcome is that these patients will go on to a pseudoarthrosis, not a fusion. And if the patient isn't very active, then, and they have limited requirements, then I think a relatively stable pseudoarthrosis is satisfactory. Whereas if you've got a person that's very active, let's say they're into sports and golf and travel, that won't be as satisfactory an outcome, because that can often be quite painful and limiting. So, but those are some of the points, Daryl, that I would consider. And the whole art here is to try to personalize the management.
Yeah, so for our participants, we just wanted to highlight what Dr. Michael Feelings mentioned. There is less use of the halo vest in this age group, especially because they already have respiratory issues, and you would not want to have them exacerbated with a halo vest. And a collar is generally used, even though collar does not immobilize the odontoid, does not help in the union, but it's more to relieve them of the pain. So, Rishi, you had a question?
Yes, sir. So, basically, this is a webinar on patients with spinal cord injury in the geriatric setting.
Right.
So, would the treatment approach, just a question to the panelists, so will the treatment approach change in case if the patient has presented with a neurological deficit with this fracture pattern?
It would for me. Yes, it would for me. So I think here then it would become a situation, again, you have to personalize the management. So if you have someone who is end of, toward the end of life, if they're, let's say, from a nursing home with significant cognitive impairment, I think there a discussion becomes, should you be doing anything or not? But if the person is reasonably active and vital, then I think that surgical management becomes extremely important. So reduction of the fracture, decompression, and stabilization. Those would be my principles of management.
Yes, thank you.
Yeah, meanwhile, we would also try to focus attention on a very important comment by Ishmeet Singh on where he says that as important as managing the fracture is to look into the prevention point of view and look into environmental and social aspects. So what was the cause of the first fall? Was it hypotension? Was it mechanical fall? Was it polypharmacy? Or was it due to lack of endurance or balance or strength? So when managing conservatively and sending someone home with a collar, things of utmost importance would be to utilize the PEO model, the person, environment, and occupation model. And it could be as simple as a multifactorial false risk assessment and issuing a frame of removing a couple of rugs. So thank you, Ishmeet, for that very important comment, and we all agree with you on this count. So if there are no other comments from the panelists, Dr. Darrell or Dr. Wafa, we move on to the next case.
The first case is a great case, very, 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 very typical. Issues that we've discussed, and I think Dr. Singh's comment was an excellent one. And just while we're pulling up the case, I've personally been able to identify patients who have had unrecognized heart block and arrhythmias, for example, as a cause of the fall. And so I thought that was a very poignant comment to actually have some consideration around what caused the fall and then around fall prevention. And then back over to our case presenter.
So yeah, the topic that we were given for our second case is a fracture and an ankylosing spondylitis or disc patient that resulted in a spinal cord injury. So essentially we had a case here where the very same thing happened in an elderly patient. So we're looking at here an 82-year-old male with ankylosing spondylitis. He was someone who had a history of frequent falls, and he presented to us with severe cervical myelopathy, and essentially he was unable to ambulate. He had been progressively using his lower extremities progressively less and less until the point that he presented to us. And when we did imaging on him, we found fractures both at C2 and L3. So in our first set of imaging, we found a non-healed odontoid fracture that was concomitant, significant cord compression at C1 to C2, and we were looking at a chronic non-union. Essentially, as I mentioned, this wasn't an acute fracture. The cord had been compressed for months and had been progressively, increasingly becoming more and more compressed over the course of months, not hours. Once the whole spine was imaged, a second fracture was found, and we had anterior and posterior column fracture at L3 that was non-contiguous with the cervical injury above. And essentially, there were 3 columns, basically, the refused segment at posterior. Looking at a definitive management for this patient, we had a posterior C1 to C2 decompression, again, occiput to C5. We placed bicortical occipital screws and lateral mass screws at C3 to C5. ORIF was done at L3, pedicle screws at L2 and L4. We did elect to not use cement in this case. And there was no brace because of ankylosing spondylitis, of course. And essentially 1 year post-op, this patient, although we were able to arrest the neurological damage, however, he was still, after intensive PT and things of that nature, was only able to ambulate assisted with a walker. And here are some of our summary points. And just some discussion points as well for the case-based panel.
Now, probably we could move to the case-based panel discussion, and the panelists for this case are Dr. Michael Fairlings himself and Dr. Rishi Khanna. So would you be able to
Dr. Rishi Khanna first? Rishi, if you could perhaps comment, and yeah, thank you.
It's a very unique case. So we don't usually see this combination. A patient who has a odontoid fracture, which has gone into a non-union, and patient has developed a chronic myelopathy. And probably the reason why she fell down now could have been the myelopathy, which resulted in the L3 fracture. So now we have an octogenarian with a old non-healed fracture with a myelopathy cord compression and a new fracture at the lumbar region. I pretty much agree with the treatment that has been done in this patient. So definitely the cervical cord compression requires a decompression and fixation, because it will be very difficult to position the patient prone without further injuring the spinal cord. So naturally the cervical region requires a decompression fixation occiput to C2 or C3 or C5 as done in this case, depending upon the bone stock. And probably it should have could have been staged. I don't know exactly how it was done in this particular case. And in the maybe a second or third stage, second stage after a week or so, we could fix the lumbar region. The one thing is I would have gone percutaneous and gone for a longer fixation. And if there is a good cleft present at the level of L3, could have cemented as well. Yeah.
So, Dr. Michael Fairlings, your
I think,
your viewpoint.
Yeah, I think Dr. Khanna has highlighted a number of important points. I think I'm going to perhaps talk about some complementary approaches. So, the case was very well managed from a technical surgical perspective. I may have also considered percutaneous screw fixation in the lumbar region with longer segment fixation. And in this setting, I will often consider cement augmentation. I agree with those points. But I think from a few different perspectives. So one would be to emphasize the medical management here, in this patient. So one really is that to have really a comprehensive assessment on the medical management. And although I'm a strong advocate for, early surgical intervention, within the first 24 hours, I think a case like this is often best handled in an early delayed fashion. So in the first 72 hours or so after surgery, or, often these patients have anticoagulants that need to be washed out. One may need to assess associated cardiovascular issues and arrange for an intensive care unit bed and various issues like this to really to manage the patient. And so I think in this kind of a setting, if you're electing to do surgery, it's a very acceptable option to delay the surgery a bit to fully medically evaluate the patient, to assess the patient. And then, and so multidisciplinary management will be required. Also, Dr. Singh previously mentioned, Dr. Chabra emphasized the holistic assessment of the patient, which I think becomes very important. What are the patient's circumstances, the family, home circumstances, et cetera, really trying to understand this, understanding goals of care, and so on. Because, the perioperative complications, even in expert hands, are going to be there. And you have to be prepared to manage those. And the mortality rates will be higher in the setting of ankylosing spondylitis, particularly in a geriatric individual with a spinal cord injury. So these issues need to become clear so that the goals of care are there. One element which is often, quite a challenge is the positioning of the patient during surgery. And there are different ways to do this. Our particular approach in Toronto is in a case like this, we actually would use a rotating table, so a Jackson type table or an Allen table trio, something like this. And we would actually do this under electrophysiological monitoring. So again, this is why, this is better done under a more elective controlled circumstance as opposed to the middle of the night. And we would have a baseline set of evoked potentials. We would strap the patient into, with a Mayfield headrest, into the Jackson type table. and then do a controlled turn, have imaging to ensure that there wasn't any displacement of the cervical fracture, and then get another set of evoked potentials to, just to, as kind of as a safety precaution. And these ankylosing spondylitis cases are very challenging, and it's also very important that when you're positioning the patient, that they be in a neutral position. So if their normal position is somewhat flexed forward, you want to be very careful with that positioning, because you don't want to try to overextend them, for example, and then you can induce a spinal cord injury, doing this. So the positioning becomes, I think, quite careful. And so, our co-host, Dr. Chabra, is an expert in the holistic management, but I think I'd be interested actually in Dr. Chabra's comments as well related to this, because I think here, this is a case that needs a tremendous amount of judgment, and you need a very strong multidisciplinary team, to kind of look at that. So thank you.
Yeah, thank you, Dr. Michael Ferenc. Rishi, would you also want to discuss with the anesthetist about some particular management strategies before taking the patient on the table? And if yes, what would those discussion points be?
Yes. So apart from understanding the comorbidities of the patient, an octogenarian naturally may have comorbidities like diabetes mellitus, hypertension, and the heart function. All of this has to be evaluated. But in particular, related to ankylosing spondylitis, assessment of the pulmonary function is very important, because a lot of these patients have a fused rib cage as well. So their lung expansion and the forced expiratory volume will be much less compared to normal individuals. So that has to be taken into consideration. And a lot of these patients may require a post-operative ventilatory support that needs to be discussed with the family. So they may require a tracheostomy for probably for a few days for a pulmonary toileting. And third thing is the maintenance of the blood pressures during the surgery, because the patient has a C1, C2 compression with a pre-existing myelopathy. So in that situation, managing the pressures is also very important, so that we don't have any hypotensive episodes during the surgery. So these are the few things that needs to be discussed with the anesthetist before taking the patient for surgery.
Yeah, I think.
And what kind of intubation would you suggest to the anesthetist for such a patient?
Generally, here we have a video laryngoscope for intubation, but if there is a concern that hyperextension or the neck mobility will be restricted in these patients, then we should be mentally prepared, and the adequate expertise and skill should be available inside the OR to have a awake fiber optic intubation in these patients.
Yeah, I think that's a great question. So this is again, why this is best done under a more scheduled circumstance, because the airway management here is absolutely critical. What we would do in Toronto, usually these are done, and it sounds like Dr. Khan is similar in your unit, but these are usually done using an asleep fiber optic technique. But we would have an anesthesiologist who is extremely experienced with difficult airway management. Often there are two anesthesiologists in cases like this. And if there were concerns perhaps around the airway, and under some circumstances, we still will do an awake fiber optic intubation as well, if there are concerns that the airway, cannot be concerned. Usually, unless there's very significant deformity, generally the asleep fiber optic can be done, quite safely. But this also, I think, requires, a very appropriate, assessment as well. Yeah. So that's a really great. That's a great comment, to make as well.
Dr. Michael Ferenc, what would your MAP goals be for such a patient? During intraoperative and preoperative both.
Yeah. So that's that's that was a point of discussion at last our previous webinar. So so currently the guidelines are to in patients to generally have a map of somewhere around 80 to 85 with a lower range kind of in the mid 70s at 75 and the avoidance of excessive hypertension beyond 95, and so trying to look at that range. And then this also requires judgment because what is the patient's underlying blood pressure? And then in addition, do they or do they not have a spinal cord injury? Because if they haven't had a spinal cord injury, you have a little bit more leeway. Not that I would allow patients to go hypotensive, but they'll be a little bit less vulnerable to this. And then the issues then become, okay, how will the blood pressure be managed? And again, a discussion with this, what is the preferred inotrope? What would be the techniques? And obviously there's a lot of judgment, and I would defer to the judgment of the anesthesiologist. In general, if an inotrope is used intraoperatively in Toronto, in most cases we will use a norepinephrine or Levophed. It tends to have the best balance between alpha and beta activity. And again, this will need to kind of be established. But those would be sort of the principles. The other issue will be, if the patient has a good level of neurologic function, you don't need to have 7 days of the ICU management. We now recognize that a shorter period of time will allow patients to get off the inotropes, because older patients, there can be a lot of complications associated with the use of the inotropes as well.
Yeah, Rishi, you had a comment to make.
Yeah. So this is a question to the panelists, Dr. Fieldings and Dr. Chabra. So if you're planning to operate on this patient and operate at both the levels, would it be a staged one? And how long would you wait before you go for the second stage surgery? Because to keep the patient in a tube for a longer time would be difficult in this situation. To extubate and then re-intubate after 3 or 4 days also would be a difficult thing. So all these things should be discussed with the anesthetist and the family before going. So what would be your surgical strategy in this situation?
Harvinder, did you want to maybe address that first, and then I can give some comments?
Please go ahead, Michael.
Okay. Yeah. So this is a great comment, and I think to a large extent it depends on the fragility of the patient and how your surgery has gone. And I think that the cervical issue is the more critical issue, and that would be my first goal. And I would likely stage this, and I think mainly because I think it's a really big deal to do the cervical surgery. I would want to get them through this. The lumbar fracture, I think, is of a less critical nature, and the techniques and so on that I would use are a bit different. But again, this is a judgment call, and then I think in this circumstance, in the lumbar area, I think the use of percutaneous screw fixation with multiple points above and below would be a very good option here in this case. And then that could be done, that's like a 1 hour procedure. And then the neck would be stabilized. You can have the patient more. That's what I would be inclined to do, but I'd have to really look at the patient and have a sense of this, and to really, where this is going. I would be open to the possibility of a staged procedure, but I tend in these patients to focus on what is absolutely required initially, and then potentially stage the second procedure later on.
Thank you.
So So, of course, Michael, it would depend on how physiologically stable the patient is. But if the patient is relatively physiologically stable, would you consider two teams working on the patient, one working on the cervical spine and the other simultaneously doing a percutaneous fixation so that you can mobilize the patient early?
I personally find that very distracting. So I I I have on a handful of cases in my career done that, and I think that it can be done, but in general, I find it very personally very distracting. Maybe this is just me, and I this is a really tough case, and I think I just want to have everybody personally. This is just me. Focus on the cervical and just to deal with it. So I think at a personal level, I know what I would do. I personally wouldn't have two teams because I would want to have all my attention focused on the cervical, get that done, and then if everything was going great and everything's like beautiful and perfect, fine, then we can get that done, and maybe while the team is closing, come down and start getting things kind of prep for the lumbar area. That's just me. That's at a this is the art of surgery. This is my personal preference.
No, point well taken, Michael. These are pearls of wisdom. So coming with a lot of experience. So we have to take that very seriously.
Can we ask Abdullah what was done in this particular case? Was it done single staged?
Yeah, thank you, Dr. Khanna, for the question. So what essentially was done, it was done all basically in one sitting. So what ended up happening was the occipitocervical instrumentation was done initially. As Dr. Michael Fillings mentioned, that's really the big issue here. And then subsequently, the lumbar posterior instrumentation was done.
Thanks.
A quick question to both the panelists, Dr. Michael Fillings and Rishi Khanna. Before taking this patient up, suppose this patient had a significant neurological deficit. It's an 82-year-old patient with 2 fractures in the spine. What are the complication risks that you would counsel the patient and the family? And what is there a significant mortality rate that we would also want to talk them? Of course, it would depend on a lot of other things like what is the physiological status of the patient, frailty, etc. But how would you counsel the patient and the family?
This person, is an octogenarian, and if they were to have a spinal cord injury, the data just on that would indicate that the complication rates are higher and the mortality rates are higher. And again, it would depend, I think, just that factor alone. So I would not discriminate on the basis of age. I would really look at the person. So if this person were, an 82-year-old who was quite vital, cognitively intact, I would just, forge ahead and try to optimize the best I could, but to make everyone aware that this was a serious issue. But on the other hand, we are faced with individuals that are very impaired, and perhaps they're quite frail and they're cognitively impaired. Under these circumstances, it is quite reasonable to consider non-operative, management, because the outcomes then will be very poor, and the patient will not be able to regain a good quality of life. So I think looking at that humanistically, it's not what I tend to prefer to do as a surgeon. I want to intervene, but I have done this. I have, we've had discussions and looking at the patient's wishes. And then in the setting of ankylosing spondylitis, any fracture in the setting of ankylosing spondylitis presents all kinds of challenges, and these patients are notorious for having high complication rates. Being very meticulous with the management of these patients, being very aware of their comorbidities and optimizing this. This is why I think probably Dr. Khanna and I may have opted for a somewhat, kind of more MIS approach. Again, this is very open. It's technical. I realize Dr. Vaccaro is an extremely skilled surgeon. I'm sure this case went very quickly, but that's something, potentially to consider. And now if we have both, an 82-year-old with a spinal cord injury and ankylosing spondylitis, you have this together, one can imagine, the complexity of this, just goes forward. And this, requires tremendous judgment and a very holistic approach to the patient, as was emphasized by Dr. Singh. We can't just look at the imaging. We have to consider the patient as a whole and the goals of care and, considering all of this. And then, of course, if we feel that, the patient is, vital and active, and if they really want to pursue this, then I think we as surgeons have a lot to offer. But we also have to, consider the person. So I think it's a tremendous amount of judgment involved with this. And I think this kind of a case, even at my stage of career, having managed many, many patients, would really, I would have to be extremely thoughtful about this case in terms of, all the management approaches.
And irrespective of the type of management you choose, there would be still a reasonable mortality rate in such patients, irrespective of the type of management, and one would want to counsel. Of course, there are a lot more questions that we would want to put across, like what would be the perioperative bleeding risk, and how do you balance that with anticoagulation considerations, etc. But we are running out of time. There's a lot more to discuss, and we would we are sure we need many more such webinars on the topic to discuss everything about geriatric spinal cord injury. But be on the lookout for gap mapping review that the Spine Trauma Study Group, along with the AO Knowledge Forum Spinal Cord Injury and the AO Knowledge Forum Trauma and Infections will be coming out with, and then a focus issue in spinal cord, which will come subsequently and will answer all such questions. Thanking the panelists, but a quick wrap-up message that we could have for the webinar. As Dr. Michael Fillings had pointed out, would want to just point out that this webinar has been organized by the Spine Trauma Study Group in collaboration with the AO Spine through the AO Spine Knowledge Forum Spinal Cord Injury and AO Spine Knowledge Forum Trauma and Infections. AO Spine is a clinical specialty of the AO Foundation, an independent medical guided not-for-profit organization based in Davos in Switzerland, as you all know. We have various pearls which have come out from the discussion today. We should remember that in every geriatric spinal cord injury patient, time matters, but patient physiology matters even more. Early diagnosis, spinal stabilization, neurological protection, and timely rehabilitation remains essential. Treatment decisions must be individualized. Stable fixation is the foundation of successful recovery. Poor bone quality, ankylosed spines, and long lever arms demand stronger constructs, longer fixation, and meticulous planning. Complications often determine outcomes more than a neurological injury. Delirium, pneumonia, pressure injuries, venous thromboembolism, malnutrition, and sarcopenia frequently have a greater impact on mortality and functional recovery than the spinal cord injury itself. Recovery extends beyond the spinal cord. Neurological recovery depends not only on neural repair, but also on preserving muscle mass, nutrition, immune function, pulmonary health, cognition, and early mobilization. And multidisciplinary care is not optional, it's mandatory. And it requires a multidisciplinary team approach with spine surgeons, intensivists, geriatricians, rehabilitation physicians, physiotherapists, occupational therapists, and a multidisciplinary team, as you all know about. In geriatric spinal cord injury, success is measured not only by neurological recovery, but by restoring independence, dignity, and quality of life. So there are various research priorities for the next decade: biology-driven interventions, understanding inflammaging and immunosenescence, as pointed out by Dr. James Guest, neuroprotective and regenerative therapies, stem cells, exosomes, biomarkers and precision medicine, strategies to improve biological recovery in the aging spinal cord. So there are also frailty adjusted surgical algorithms, moving beyond chronological age, frailty based decision making tools, etc. And then prevention bundles, standardized protocols for preventing various complications like delirium, pneumonia, etc. Fixation innovation, improved implant design for osteoporotic bones, smart instrumentation, etc. So we are moving from age-based care to physiology-based care, from fracture fixation to functional recovery, from isolated surgery to integrated multidisciplinary care, from treating complications to preventing complications, from generalized protocols to personalized precision medicine. Ultimately, the future of geriatric spinal cord injury management lies at the intersection of better biology, smarter surgery, comprehensive rehabilitation, and collaborative multidisciplinary care. The message is clear. The elderly patient with spinal cord injury deserves not simply longer survival, but better recovery, greater independence, and an improved quality of life. So thank you all for your participation and commitment to understanding the care of patients with spinal cord injury. Together, let us ensure that advancing age is never a barrier to excellence in spinal cord injury care. So stay safe, continue collaborating, and we look forward to welcoming you to ISICON 2026 in New Delhi, where more such things would be discussed. And this webinar is also part of the academic series of ISICON. We look forward to our future initiatives on geriatric spinal cord injury management as well. And we thank you for all participation, especially the chair, Dr. Michael Failings, the various panelists, Dr. Daryl Fields, Dr. Wafa, Dr. Rishi Khanna, and the presenters, Dr. Klaus Schnake, Dr. James Guest, and of course, Dr. Alex Vaccaro and his team, Abdullah Mahmood for the wonderful cases that he and others like Roy put up, and we had an interesting discussion, and look forward to collaborating further on this very important and interesting topic so that we can have better outcomes in such patients. Thank you very much. Thank you.
Thank you all.